Hi, my name is Kenneth Barker. I'm a medical student at OUWB, and this is a case report of subacute endocarditis in a previous healthy man with an undiagnosed bicuspid aortic valve. So to move to the intro, congenital bicuspid aortic valve, it's a structural abnormality of the heart. It's thought to affect about 1% of the population. The thing with bicuspid aortic valve, it's pretty hard to diagnose because patients are usually asymptomatic until they're about like 50 years old. So if you're not looking for it, there's no really reason to pick it up unless you're really good at listening to murmurs, and you might pick it up. So with infective endocarditis, usually a source of infection is found in the HPI or physical, maybe like someone's using drugs or with needles and introducing bacteria into the blood. But in a structural abnormality, such as bicuspid aortic valve, just transient bacteria itself can sometimes be enough to seed the valve or wherever the carditis is going on. So infective endocarditis can lead to a lot of life-threatening morbidities, and so kind of the purpose of this presentation is to kind of give hopefully some earlier index of suspicion and hopefully raise awareness of the typical presentation of infective endocarditis in maybe a younger patient. So to illustrate this, HPI, so a 37-year-old male, he presented with several months of fevers, night sweats, fatigue, unintentional weight loss of about like 40 pounds or so, and he had food aversion since September of 2020. Tests ruled out HIV, Hep C, Hep B, hypothyroidism, EOA. And then finally, a month later, they were suspecting maybe endocarditis. So they did an outpatient echo, and that showed the bicuspid valve, and then a pretty hefty mass on the aortic valve, causing severe aortic regurg. And then he was immediately admitted for inpatient eval. As people kept asking him, he explicitly denied any drug usage, needle usage, or any recent tattoos, and his last dentist appointment was pretty far away from the onset of his symptoms. Past medical history, non-contributory. Past surgical history, really non-contributory. Same family, social. Jumping down to his physical, his vitals were stable. He's afebrile. His heart rate is a little high, but otherwise vitals were good. He was slightly sweaty and diaphoretic on exam. He had a faint 2 out of 6 diastolic murmur at his left upper sternal border, but no evidence of JVD, pedal edema. Peripheral pulse is palpable. The only other really significant finding he had was it was like 3 2x3 millimeter non-tender lesions on the palmar side of his right hand near his like thumb and index finger. And he said he hadn't noticed those had noticed those previously. This is just a timeline of his diagnosis. I won't go through all of it, but kind of the highlights: CTA done on November 19th, so a day after he was admitted, showed the regurg as well as the vegetation as well as an abscess that was new. Around his aortomitral curtain area. So cardiothoracic surgery consulted at that point. He had 2 separate blood cultures, strep viridans. Started on ceftriaxone, and he was feeling a lot better after antibiotics, and then underwent a valve replacement successfully. And then kind of follow up, he's doing well currently. Kind of sounds like he's ramping back up into things with light yard work and stuff like that. This is a picture of his CTA. You can see the vegetation right there on clinging to his aortic valve area. To jump to kind of clinical diagnosis, if you have pathologic evidence, you can definitely diagnose this. But if you don't and you need a clinical diagnosis, typically Duke's modified criteria is used for infective endocarditis. So to use Duke's, you need 2 major, 1 major, 3 minor, or 5 minor. In our patient, he had 2 major, 3 minor, and I've highlighted in red. So he had 2 blood cultures, strep viridans, and he from 2 separate sites. That's important. And also, these were taken before he was started on antibiotics. So important to take the blood cultures, then start antibiotics. On echo, he had the vegetation, abscess, and regurg. All 3 of these. You only need 1, but he had all 3. He had a bicuspid aortic valve, his fever, and then Janeway lesions, those non-tender lesions there. I kind of put the phys here. I don't have time to go through them because of the 5-minute restraint, but you can read that if you're interested. So complications, here's some of the more morbid ones. I wanted to just touch on his abscess. So this was the proposed area, his aortic mitral valve curtain area. It was a good thing that his abscess didn't extend into the high real estate area of his conduction tracts. Heart block is frequently seen in these patients. Also, bicuspid aortic valve has a genetic component, so screening was recommended to his first-degree relatives. And so in conclusion, this is a highly treatable disease if diagnosed early. In this case, just serves the importance of diagnosing early and preventing some of those more morbid complications from developing. Thank you.